Hello, this is your brain on drugs and the punk rock psychiatrist. So today I made an update of the lactation guidelines, but I made that right after the episode. So this is actually an update of an episode that aired a few months ago, um, which will probably be a series of updates. So sometimes these updates are going to be new information that's kind of come out since I did my episode, and sometimes they're just I got more information. And this is a case of I got some more information. So I did the episode on the kind of life course of medication use, how long to take it, what to expect over time, when you could discontinue it, how to discontinue, what the guidelines are on how long to take it, um, how many trials of medications it takes went over the STAR-D trial. If you remember that episode, it was all that stuff. I kind of crammed a lot in there. And I had one slide on discontinuation. And I've come across some pretty cool information I wanted to share with you all. Um, and I'm going to go into more detail. So I looked at my slide for discontinuation, and all the points I found basically kind of tapped on every point I made, but gave a lot better detail and a lot better information. And so I wanted to go ahead and release a shorter, updated episode on that. So just to review that slide. So if you have the slides, I haven't put the updated ones yet up there that have the new slides on there. But if you have the current ones, it's a slide that says discontinuation of therapy. And I made a few points. One, if you're treated for an antidepressant, you should probably take it for 9 to 12 months to make sure that whatever kind of changes in the brain happen are more likely to be permanent and that we avoid getting a relapse. That was one point. Second was if you're going to stop it, you should probably decrease it slowly. And the longer you've been on it, the slower you should probably decrease it. Um, and then then I mentioned, the warning signs of withdrawal so that we kind of can tell the difference between whether this is a relapse or a withdrawal. Withdrawal meaning, I'm having these symptoms because I was taking the medication and now I'm not taking it anymore. Relapse meaning that my symptoms of depression have returned. And then I made one last point of long-term therapy may not be necessary. So those were kind of the points, and I actually found this really cool information, and it went into each one of these points in more detail, and I wanted to share that with you today. So on the first point, patients should be treated for at least 9 to 12 months before considering taper. Um, and I think my stance on this had been, and what I had said in the episode was, I encourage people to take it at least this long because it decreases the chances that they're going to get a relapse. Um, and then I said that at that point, I kind of leave it up to them. If they want to keep going, let's keep going. If they don't want to keep going, that's a good time to consider stopping it. However, what I've kind of run across was maybe I should be encouraging them to get off once they've been on at that period of time, and maybe if a few there's some factors that will play into that. So let's talk about that. Because I had always just kind of thought, well, if the patient's anxious to get off, I'm going to be cool with it at that time. But if they don't, then I'm also cool with just, I'm not going to say, hey, maybe you should try getting off. I'm not going to say that to them. I think I'd do that now. I think I would. So these are some interesting facts. Long-term use is not needed for most patients. So that's the first thing. Um, you can't like the thing is you've had one episode of depression, you're right. So especially those that had mild to moderate symptoms in a single episode. So if your symptoms weren't that severe, like this is not a suicidal patient, this is not a severe major depressive disorder. They had one episode in their entire life. Um, this is the kind of person that definitely should be trying to get off medication. That they've never had a relapse before. Their symptoms weren't even that severe, and I'll also add the caveat that these guidelines I found were directed at family medicine, specifically general practice, because they came from Australia and that's what they call it there. Um, so the thing is, family medicine is tending to treat the milder patients, the milder to moderate patients, the single episode, the less severe cases, and the more significant cases, the more difficult, challenging cases come to psychiatry. And I talked about that on another episode of, we're getting the treatment resistant folks, the ones that aren't responding to treatment. So as the psychiatrist, we kind of have the problem of, oh man, we're already getting the folks that have failed all these treatments and are not doing that well. And what's the chances they're going to respond to something else? Well, we do have other tools in our toolkit that maybe family medicine doesn't. We looked at the STAR-D trial. We saw, okay, there's like 4 rounds of treatment with different types of medications. They're probably not going to give people lithium. They're probably not going to give people thyroid hormone, TCAs, MAOIs, things like that. We have some other tools, right? So, and then we have some other tools, listen to those episodes where I talked about how to deal with treatment resistance. But then also, because they're having such an easy time at things of, oh, I just gave somebody an SSRI and they got better and we'll just keep going. And people tend not to go back and see their family medicine doctor unless they're sick. And so they just keep getting refills, asking for refills, and taking it forever. Probably even more so than they do when they get them from us. And those folks probably don't need to take them. And I know we don't always get treatment resistant patients here in psychiatry land. Oftentimes we do get these milder to moderate single episode cases. And even the ones that aren't that, a lot of those folks probably don't need long-term treatment. So I think, you know, when I'm thinking about long-term treatment, I'm like, someone's had several relapses, meaning that, they took medication, it helped, they took it for a long time, we came off slowly, and they were relapse, not withdrawal symptoms, and we had to restart treatment, and then maybe we did it again, and it came back again. And I talked about the percentages of that in that episode as well. And the more times you have it, the more likely it is you need to take it long term. So there's definitely people out there that need to take it long term. But the thing is, if it's like your first time, you don't know if you're that person. And the thing is, there's consequences. Let's talk about those. So the adverse effects of these medications can be bothersome long term. And we've talked about these in the side effect episodes for the serotonergic medications: emotional numbing, fatigue, weight gain, sexual side effects, right? And this is the dirty secret. Those sexual side effects sometimes don't go away after you stop the medication. And then risks of falls in the elderly, right? So we're getting lots of problems from these medications. And even if the patient thinks they're tolerant, actually had a patient today that I saw that had taken a tricyclic for migraines, not for depression, for 6 years. And it took that long when they finally realized, oh my gosh, this is an antidepressant. Oh my gosh, this is causing all these adverse effects. And I didn't even realize that I was having them. And I didn't even realize that it was from this medication. And it helps, but I don't need it that badly for it to be worth this. And that's the case with so many people. Like, they may not notice the adverse effects, and once they've been taking it for so long, it just becomes a part of their life. And so they may not realize they've been emotionally numb for years because they've been on this medication. They may not realize that their sexual functioning is not the way it was before, and it's because of the medication, not because of something else or whatever, right? And sometimes it is, sometimes it is, sometimes it isn't. And that's the tough job we have to try and decipher that. And that's why I often test discontinuing for patients to see, let's just try getting off this and see what happens. Okay. And here's the other thing: the deprescribing, and deprescribing is an issue with lots of medications, like the medications for GERD, like basically heartburn, medications for that's the one I remember. There's several conditions where people basically end up on these things. They're started in the hospital or whatever. There's and they're just kind of continued forever, and they can they can be stopped. And there's organizations out there that talk about how to deprescribe those medications. Well, I found an organization that talks about deprescribing um, antidepressants, and they're not an anti-psychiatry organization. They're actually a medical institution um, that we'll talk about in a second. So here's the other thing: deprescribing of antidepressants is often not even brought up to patients, and they're just continuing on these medications for years. Okay. So if we're going to stop antidepressants, this was the point I made in my slide. All antidepressants should be gradually titrated down, right? But the information I found recently kind of went into detail on that. So, what are some factors to select the speed of taper? So, the type of antidepressant, SNRIs, paroxetine, mirtazapine, right? These shorter half life norepinephrine medications, they tend to be more difficult. 40-oxetine, bupropion tend to be less difficult, and the rest of them kind of in between. Then the duration of therapy, how long they've been on this therapy. The longer they've been on, the longer the taper. What dose they're on. People are on higher doses need a longer taper. Past experiences withdrawal. So if they've had withdrawal in the past when they've tried to come off medications, they need to have um, a slower taper. And so this organization I'm going to go into in a second, they're called Release in all caps, and they actually have an. If you go on their website, and it was a little hard for me to find this. If you search for Release, you're going to find basically a study protocol where they're gathering information in 2025 about studying this exact same thing. But I dug hard, and I actually found their protocol because I was like, okay, you haven't done the study yet, but they've actually done other studies. I was like, what is your protocol? I was able to find it linked through another website. So I found like the Australian General Practitioners website that was recommending using Release, and they had a link, and then I went to that link, and then you have to put like your name and email address, and they don't even use it. They don't. I haven't been emailed at all, and then you submit that, and then you get to the place where you get all of their like information, and there's all these PDFs on like talking about this situation and a lot of the things I'm going to report to today. You could go on their website and get all that information, but I was just going to summarize it for you. So they actually have one of the PDFs they have as an algorithm, so that you can select the speed of the taper, whether it's a slow, or really slow, right? And they take those for you actually like what meds were they taking, how long you've been taking it, what dose, what their past experience, and it adds up like depending on your answers. There's numbers. It's like a scale, and then whatever number it adds up to at the end determines what speed of taper that you should do for this particular patient. So I actually thought that was kind of cool. And they're like, I don't know if it's validated yet, but they're continuing to publish things, and it made a lot of sense to me. So, Release, what does that stand for? It stands for redressing long-term antidepressant use, and they pull those letters out of like the middle of those words as well. So they like the word release because you're releasing from medications. It's actually from the University of Queensland. For those of you that don't know, Queensland is a state in the country of Australia. So like this would be like the University of Texas, which is where I went. So University of Queensland, it's a major university. It's like the major state university in Queensland, which is one of whether like six states in Australia. So there's millions of people that live in this place, right? This is their major university, University of Queensland. It was their research was funded by the National Health and Medical Research Council, which I think is probably a little bit like the NIH in the United States. It was designed for general practitioners, which are like primary care, and it's been endorsed by the Royal Australian College of General Practitioners. Okay, so that's kind of like um, American Academy of Family Physicians. Yeah, so it's endorsed by the main Australian um, organization of general practitioners, right? So this is a highly like regarded organization. This is not some crack unit, crackpot folks that are just like anti meds and anti don't believe in depression and stuff like that. They're folks that are genuinely concerned about folks that like get on these meds, maybe for a good reason and really helpful for a while, but just never get taken off. And maybe we should think about it. So you can actually, I'll read off this website, but like eventually I'll post the slides. But if you search for the Royal Australian College of General Practitioners and Release, you'll hopefully be able to find it if you're looking for it. It's at www.racgp.org.au/clinical-resources/clinical-guidelines/guidelines-by-topic view hyphen all hyphen guidelines hyphen by hyphen topic slash preventative slash health hyphen health slash release hyphen resources. So it's pretty long. And like I said, it did take me some work to find it. But you can actually go on there and find the tapers for 15 different medications that are antidepressants. Four of them are ones like reboxetine and mepronoline and stuff that we don't really use in the United States. But 11 of them are that they have pretty much all the SSRIs, most of the SNRIs, mirtazapine, vortioxetine are all on there. So it's most of what we'd be using. Bupropion, I don't even know if they have bupropion in Australia, but that one's not on there. Vilazidone's not on there. But those are really the only two big ones that we're missing that are like kind of the modern antidepressants that we use. And so I just wanted to show you an example for sertraline because that's the most common antidepressant prescribed. And so they had what they called a fast taper, a slow taper, and a slowest taper. So they had three. Interesting, venlafaxine doesn't have a fast taper, which makes sense to me. They have a slow and a slowest, which I agree with. But remember, you go through the algorithm of like how long they've been taking it and all that sort of stuff, and you find out whether you should use the fast, the slow, or the slowest. So with the fast, this is actually quite interesting to me because I taper faster than the fast, and I think that was kind of their point, was that people are getting tapered too quickly. So the fast taper, they said every 2 to 4 weeks, you make a change. So you're on 100, and remember these doses are every 2 to 4 weeks you go to the next dose: 100, 50, 25, 12.5, 9, 6, 4, 2, and then 1 milligram. And for the 1 through 9 milligrams, they're using the liquid. So I mean, they tell you exactly what to do of combinations of pill sizes or combination of pills and liquids to try and get these like really small increments. Some of which are like when we move to the other ones, it's even more. So like the slow taper every 2 to 4 weeks. This is incredible. I mean, this would take like a year to go through this. More. I mean, at 2 to 4 weeks. 100, 75, 50, 37.5, 30, 20, 25. I think the 20 was thrown in there. So 25, 20, 15, 12.5, 10, 8, 6, 5, 4, 3, 2.5, 2, 1.5, 1.5. And then there was a slowest taper that I'm not even going to read. It had 39 steps. And so you're thinking, wow, this sounds a bit excessive, because that's what I was thinking. But here's the other thing. I don't, as a military provider, I really didn't encounter a lot of people that had been on these medications for years and years that were wanting to come off. It's not something I saw that often. It was folks that, there wasn't great adherence. A lot of people stopped on their own. They would take it a few months. Maybe they were on it a year or two at the most, but not a lot of real long-term use with the patients I saw in my population. And so I think if you haven't been taking it that long, you don't have to be concerned about these really long tapers. And a lot of what they're doing with these really long tapers is trying to avoid like these what's called prolonged withdrawal, which I'm going to mention in a second. So I think this is probably most pertinent for people that have been taking it longer. And it's to avoid these withdrawal symptoms, which we're going to talk about next. So first, and I talked about this a little bit, but I did like how they delineated this withdrawal versus relapse. All right. So like distinguishing between withdrawal and relapse is extremely important because the patients often are unable to do this. They experience a withdrawal. They think it's relapse. They restart their medication. Withdrawal, otherwise known as antidepressant discontinuation syndrome, is really common. Around 20% of people get it. Okay. And then there's this thing called prolonged withdrawal. And amongst people who have been taking medication for years, it's not uncommon. I think I have heard this a few times, and I didn't really even put two and two together, but I have had patients that said, they came off medications and they continued to have these withdrawal symptoms and they just like never went away and they just like couldn't get off medication. So I just kept restarting it. So how do we tell the difference? All right. So there's time of onset and time of relief. So if these symptoms that you're getting, whether relapse or withdrawal, whatever it is, happen really quickly after you stop the medication, that's withdrawal. That happens within days. Relapse, weeks to months before you're going to have the symptoms. And then the same thing with time to relief upon restarting. So you stopped, you got the symptoms, you started the medication again, you felt better really soon. If you feel worse really fast within days and you feel better really fast within days upon restarting, that's probably withdrawal. Relapse takes weeks to months for both. It takes a while before the symptoms come back, and it takes a while before the symptoms go away again when you start the medication again. Okay? So that's one key difference. The other thing is the symptoms aren't the same. Withdrawal tends to be a lot of physical stuff: dizziness, lightheadedness, vertigo, headaches, brain fog, brain zaps. I know we probably all heard that one, or these electric shock sensations. So these weird sensations of like zaps going through their body, right? Photophobia, so like sensitivity to light; phonophobia, sensitivity to sound; nausea, sometimes sensitivity to touch; sweating; tremors; vivid dreams; muscle aches; agitation; akathisia, just restlessness. Those are all symptoms that sound like withdrawal to me, right? Relapse, you don't really get these physical symptoms, okay? Um, with relapse, what happens is you get the symptoms that you had before. You get like the symptoms of depression or anxiety, whatever you were treating with the medication. Your sleep is bad, your mood is low, you're having thoughts of hurting yourself, those sorts of symptoms. Some of those might overlap, like the psychomotor agitation retardation. Some of that stuff might overlap, but these like brain zaps and dizziness and nausea and things like that, those are not symptoms of depression. Those are symptoms of withdrawal of medication. All right. So important to kind of know the difference. And the thing is, if the patient is getting these withdrawal symptoms, that's not a sign that they can't stop medication. It's a sign that they can't stop as quickly as they're stopping it. And that's where the very slow titration schedule comes in. So that just means, okay, this doesn't mean that we need this medication. This is not your depression coming back. This is just withdrawal symptoms from the medication. And I often, I get these questions like, am I going to be addicted to this? And I always say no. And I think most physicians say no, these are not addictive medications. But typically, I mean, withdrawal symptoms are something we associate with addictive substances. And addictive substances, like things like benzodiazepines, you have to come off really slowly. Well, um, maybe not for most patients, but for a handful of patients, I mean, only 20% of patients get the withdrawal symptoms. So 80%, a lot of people just stop cold turkey and they feel fine within a few days. Um, I don't think that's a good solution for like preventing them from having a relapse. I think they should go slower for that. But like for these 20% of people that are going to get withdrawal, most of them, if they're going to feel like crap for a week or two, maybe, and then they're going to feel fine. But a handful of people get this thing called prolonged withdrawal, which is something that people get from substance abuse. This is a term that's used for substance abuse. You get prolonged withdrawal from opiates or benzos or something like that. You can actually get this from particularly serotonergic medications, of the antidepressants. And so I think, you know, being more aware of this and being aware that like the difference between these symptoms, one, asking the question, does this patient really need to take this forever? Can we try getting off of it? And if we try to get off of it, let's go, let's determine how quickly we can get off of it based on a number of factors that I covered. And then what kind of schedule do we want to do? And the thing is, you can adjust that schedule. If the patient's getting withdrawal symptoms, slow down, keep the dose that they didn't have them on a little bit longer, and then make a smaller step down. And you can, like, you may, if you want to know how to have these smaller step downs, there's different pill sizes. So you could do things like taking a 50 and cutting a 25 in half, and taking that half the 25 with the 50, right? You sometimes they make even a smaller one, and they make a child size one. They make the liquids. You can dose out those liquids into milliliters, right? And you can combine that with a 50 milligram pill, right? So there's ways to go down extremely slowly. When I talked about venlafaxine, I talked about pouring it into a graduated cylinder 100 milliliters and dissolving the pill into there, and then pouring off 1 milliliter and drinking 99 millimeters, and the next day 98, and the next day 97, right? And I give venlafaxine a hard time because this withdrawal symptoms on venlafaxine is, in my experience, by far the worst. And this like withdrawal and prolonged withdrawal with that is my biggest concern. It's why I don't use it. And this is why I never prescribe venlafaxine. I never prescribe it. I refill it if they're on it, but I never start anyone on it because of that, because it is the biggest culprit for that happening. And I even, we even listed that. What are the biggest culprits? The SNRIs, but particularly venlafaxine, paroxetine, fluvoxamine, also mirtazapine. They're the hardest to come off with. Mirtazapine was kind of a little bit of a surprise for me, but they did include that one there. So um, I would just I would take that into consideration. And then if you've got someone, don't you yourself think that they're having a relapse. Consider the withdrawal symptoms and consider going slower and consider the fact that there is reason to come off this. I read several case reports of people that had this prolonged withdrawal and then they restarted medications. And even upon restarting, they couldn't get rid of the withdrawal symptoms. And they were just plagued with this for a decade. So, and when you see a patient like that, think to yourself, oh, maybe this patient's having a prolonged withdrawal. And this is why fluoxetine can often be a good idea because it has such a long half-life, and you can actually use fluoxetine to help with the withdrawal. Maybe you replace the medication that they're taking with fluoxetine and taper off of that. It's easier to taper off of fluoxetine because of the long half-life. It comes out more slowly. It has like a more graduated discontinuation curve of like getting out of your system. But yeah, I just wanted to have like a half episode to kind of update that, give you that information, and put a plug in for release. I listened to another podcast that's from Australia that's a substance abuse podcast, and he brought it up, and it was really intriguing to me. I found their website, I read all over it, I found all this information. It sounded really interesting to me, and I just wanted to throw together a little update podcast for the discontinuation. And so, I'm just going to throw this one in the middle of the week and hope you enjoy it. I'll see you next time.